respiratory pathology, atelectasis, as well as pleural effusions. So for atelectasis, there really isn't much that you need to know. All it is just alveolar collapse. So the alveoli cannot open up. And one of the main pathologies associated with atelectasis is going to be our NERDS, okay? Neonatal respiratory distress syndrome, right? We already discussed what NERDS is. You have a decrease in surfactant, so that means that you have an increase in surface tension on the alveoli, and that leads them to collapse. And if they're collapsed, that means that it's a form of atelectasis, okay? Very, very important. It's called an adhesive atelectasis, okay? And you're going to see ground glass opacities for patients that have NERDS that also have atelectasis. Okay, that's the only thing that I care about for atelectasis. You can care all you want. You can learn it if you want, but that's probably the only thing that they could potentially quiz you on. Next is pleural effusions. Pleural effusions, I'd say that I got probably roughly around 50 questions on pleural effusions. So it's so high yield. You have to know it. You have to memorize it. And I didn't take the time to actually learn it, but once I learned it, it's so easy. I just wish I got it out of the way like quicker, and I could have just gotten all the questions correct. So here's how you know pleural effusion. So what is pleural effusion in the first place? Pleural effusions is just accumulation of fluid between the pleural layers. Okay? That's all it is. And the way that they treat it is they do a thoracentesis, and that means just the removal of the fluid between those layers. Okay? Now, there's two types of pleural effusions. There's exudative and there's transudative. So exudate and transidate are the two types of pleural effusions. How do you differentiate between them? This is something that I wish I knew going into it, and I should have known it because it's so clear and so obvious, okay? There's this thing known as Light's criteria, okay? And so for Light's criteria, you have to know two things, and those two things will help you differentiate between exudate and transidate. The first thing is our protein levels, okay? So if you take a sample of your pleural effusion, and you take the proteins from that pleural effusion, so the pleural proteins, and you put it over the total amount of serum proteins that you find it. So you take from the blood and you measure the amount of protein in the blood, and you do a ratio, okay? If you find that the pleural protein over the serum protein ratio is greater than 0.5, that means it's exudative, okay? So pleural protein over serum protein is greater than 0.5, that means it's exudative. So that means that you have a high amount of protein within that pleural effusion. It could be exudative, so greater than 0.5. Next, the second thing I look at is the LDH level. Pleural LDH level to serum LDH level, okay? That ratio, if it's greater than 0.6, it's exudative as well. Okay, so those are the two things that they're going to test you on. They're going to give you your effusion protein level and your serum protein level, and they're going to make you do the math on it really quickly. It's very easy. If it's greater than 0.5, it's exudative, okay? And then they'll also give you the LDH of the effusion, and they'll give the LDH of the total serum. And you're going to do pleural effusion LDH over serum LDH, and if it's greater than 0.6, that ratio, then it's exudative as well, okay? Now, they're not going to just give you the answer, oh, is it exudative or is it transudative? No. They're going to make you calculate that Light's criteria, so those two things. There's a third portion of the Light's criteria, which isn't important to me. So they're going to ask you to calculate those two things or one of those two things to help you figure out whether it's exudate and transudate. And the question they're going to ask you is what's causing it, okay? So once you figure out whether it's exudative or transudative, right, it's going to be transudative if it's less than 0.5 or less than 0.6, right? So if it's exudative, that means there's increased protein and LDH within the pleural effusion. It's going to be usually due to, secondary to infection, okay? They love to ask about that. Infection, malignancy, or a blockage in the thoracic duct, lymphatic ducts, okay? Those are the three things that cause exudative fluid. I'm going to repeat them again. Infection, malignancy, and a blockage in the lymphatics of the thoracic duct is one of the examples. And it leads to an increase in vascular permeability, okay? And so you're going to see a cloudy fluid, okay? That is the most important thing. Exudative has greater than 0.5 for pleural protein to serum protein ratio and greater than 0.6 for pleural LDH to serum LDH ratio. Okay, it's due to infection, malignancy, or a blockage of the thoracic duct lymphatics, and it causes an increase in vascular permeability. Boom. That's it, exudative. Transudative is going to have pleural protein to serum protein ratio less than 0.5 and a pleural LDH to a serum LDH ratio less than 0.6. And transudative is going to have two types, either an increase in hydrostatic pressure, secondary to either heart failure or sodium retention, or a decrease in oncotic pressure, which is secondary usually to nephrotic syndrome or cirrhosis. Okay? Does that make sense? I want it to be as clear as day. Exudative is vascular permeability increases. due to infection, malignancy, or blockage in the duct of the lymphatic drainage. And transitive is due to an increase in hydrostatic pressure, okay, secondary to heart failure, usually, or a decrease in oncotic pressure, secondary to usually nephrotic syndrome or cirrhosis, right? So if I ever see an increase in hydrostatic pressure or a decrease in oncotic pressure, the answer is going to be transitive. If I ever see an increase in vascular permeability, the answer is going to be exudative. And that might sound similar, but they're not similar. You have to differentiate those two. Okay. Now let's talk about why heart failure leads to an increase in hydrostatic pressure. Well, heart failure leads to a buildup and backup in all of our fluid, and that causes an increase in pressure on the inside. We have an increased fluid on the inside of our vasculature, and that leads to an increased pressure pushing out on our vasculature, and it leads to an increase in hydrostatic pressure. Hydrostatic pressure leaves the vasculature. High goes by. Hydrostatic pressure leads to it push out of the vasculature, so fluid leaves the vasculature. Now, why decreased oncotic pressure is caused by cirrhosis or nephrotic syndrome? Well, nephrotic syndrome, we pee out our proteins like albumin, or cirrhosis, we have liver failure, and liver usually produces our albumin and our proteins. And so when we lose that, protein usually keeps in all of our fluid, right? It attracts all the fluid. So if we have protein in the serum, it attracts the fluid to stay within the vasculature. Well, if we lose that protein through nephrotic syndrome or cirrhosis, then we have an overall decrease in colloid or oncotic pressure, okay? And so that just allows for the fluid to essentially just not want to come in. Okay, so it's not attracted to coming in. All right? Very, very important, very high yield. Make sure you understand the pleural effusions. If you need to reach out, please do. And that's all.